So if you will please join me in give Dr. Gerber a warm welcome, and we'll let him get started.
Diane, thank you for that wonderful introduction. And it's truly an honor to be here. I must say I've been bugging Diane for 4 years to come. What took so long, but I'm happy to be here. So I'm in a bit of a pickle, and I am so because I have patients that seek my advice after starting non-standard diets. The problem is that their previous doctors see changes in their cholesterol profile that they deem unfavorable. And as a result, they recommend more standard low-fat, low-calorie diets and to start cholesterol-lowering medication. And so it's at this point that the patients come running to me, wanting me to tell them that they can stay on their diets and that they don't need to take the cholesterol-lowering medication. So the question is, what am I to do? So I hope to provide some perspective today. So am I a cholesterol expert? I'm not a cardiologist. I'm not a lipidologist. I'm not Chris Masterjohn, Dr. Masterjohn. If you are familiar with him, he's a wonderful supporter and contributor to the Weston A Price Foundation on a national level. And I think he is an expert. But what I am is a primary care doctor who has been focusing on nutrition as a tool to treat and prevent chronic disease. And since cholesterol is intimately tied to nutrition, I'm obviously fascinated and interested in it. I've been a primary care doctor for almost 25 years, treating people's cholesterol, and I'd like to share what I know with you at this time. So we're going to hopefully take an entertaining look at the history and the background as it relates to cardiovascular disease. We're going to look at 4 patients. We're going to look at advanced and standard lipid testing. And we're also going to look at their non-standard diets. And we call them non-standard because these diets tend to be lower in carbohydrate, higher in saturated fat, higher in food quality and nutrient density. And at the end, we'll take a look at affordable care. So you may be familiar with the historical headlines regarding cholesterol, and this is from Time magazine in 1984, when they talk about cholesterol and now the bad news. And then it's shortly thereafter in 1986 that the National Cholesterol Educational Panel declares war on cholesterol. And if you look back, it seems that we've declared war on cholesterol ever since the pathologists saw it within the plaque of the blood vessel. And this reminds me of the Cold War. And yes, this is an eerie but rather beautiful picture of the first underwater experimental nuclear detonation that occurred in the Marshall Islands in 1946. And it was testing like this that eventually led up to the Cold War in 1962, and lucky for us, ended in the 1990s, and nuclear holocausts never happened. But when it comes to the war on cholesterol, it has been endless. In fact, it's as if we're still living in black and white, and maybe the weapons have changed, but the war rages on. And so let's take a look at this historical relationship between cholesterol and cardiovascular disease. And there's really 2 components to it. And the first is that of the diet-heart hypothesis that was made famous by a scientist named Ansel Keys. And he had suggested that eating saturated fat in the diet would raise cholesterol and thus lead to cardiovascular disease. Now, despite 60 years of research, the researchers have been unable to prove this. In fact, quite the opposite appears to be true, that there is no causal relationship between the consumption of saturated fat and cardiovascular disease. The problem is that most physicians and healthcare practitioners today still believe saturated fat to be a problem. The second component, which is often confused with the first, is that of the lipid hypothesis that is really made famous by the pharmaceutical industry, and that artificially taking a medication to lower a risk factor would reduce cardiovascular risk and disease. Now, Some medicine may have a small effect in terms of addressing inflammation, but again, despite what most doctors believe today, the risk-lowering effect of these medications are not that impressive, and we'll talk about that. So, let's jump ahead to 2014, and the message is, cholesterol is the enemy, and the weapon of choice, statins. And here we have our friend Sanjay Gupta reviewing the cholesterol guidelines that just came out last fall. And as you can imagine, they're controversial for the main reason that the guidelines recommend that a significantly greater number of patients would be taking cholesterol-lowering medications. Now, these guidelines represent a conspiracy, I mean a collaboration. I always get that wrong. But this collaboration is between the American College of Cardiology, the American Heart Association, National Heart and Lung, and the federal government. And rather than look at the obvious, let's take a look at the not so obvious. And the first is that the absolute risk reduction for primary prevention is only 1 to 2%. Another way to describe this is that if you take relatively healthy patients that are free of heart disease and you want to lower their cholesterol with a medication, I would have to put 100 to 150 patients on the cholesterol-lowering medication, specifically a statin, for 5 years to prevent one cardiovascular event. Yikes. Okay, it's dismal. And for secondary prevention for patients that have already had a heart attack, the risk reduction is only 4 to 5%. It's not very impressive. The previous president of the American College of Cardiology has already pointed out that the risk calculator is flawed and actually overestimates risk in some. The panels must have had blinders on when they came up with these guidelines because they basically ignored side effects such as liver toxicity, diabetes, dementia, rhabdomyolysis, and they basically said, if you have these side effects, after reviewing it, and I reviewed it thoroughly, the message is tough. We don't want you to have a heart attack. As you can imagine, cholesterol-lowering therapy was controversial even before the guidelines came out. Even mainstream doctors were questioning the risk-to-benefit ratio. And even now, doctors are challenging the evidence that the panel used to come up with these guidelines. These guidelines, unfortunately, block innovation, both on the medical side and the nutritional side. And the guidelines leave us with one therapy to lower cholesterol. And it leaves us with one question: to statin or not to statin? And as Prince Hamlet contemplates, he must be cautious because he knows that his choice could have devastating consequences. And so, before getting into some new theories about cardiovascular disease, let's talk about obstacles to change. And the biggest obstacle is ourselves, being human, that we're arrogant, we're stubborn, we're unwilling to change, and we're unwilling to admit that we're wrong. And then we take a group of like-minded individuals and we institutionalize an idea through government and industry. And they capitalize it through both financial and political gain. And you can be certain that very little is going to change. And despite advances in science and technology, when these groups remain resistant, we have to call it pure stupidity. So let's define stupidity for a moment. And there's no better way than in one of my favorite movies called Idiocracy. Anybody see it? Thank you. Me too, I love it. So Idiocracy tells a story of evolution going in the wrong direction, where there's a dumbing down of civilization. Now maybe it's because everybody's on statins, but nobody knows for sure. So we have our hero, Joe Bowers, here, played by Luke Wilson. And he finds himself in the middle of a human hibernation experiment. And he's catapulted 500 years into the future. And he awakens to a world of stupid people. And as you can see, here's Joe in front of the presidential cabinet. And they're so stupid they can't make any decisions. But no worries, because big industry has taken over. And we really have to thank one of the food industry leaders named Brando, who basically bought the FCC and the FDA so that they could say, do, and sell whatever they wanted. And so here's the new food pyramid, and then let's take a look. So we have lots of Brando, which by the way is a sports drink. We also have food groups including grease, smokes, caffeine, and convenience items. This looks too familiar. And so Brando, the thirst mutilator, comes to replace water virtually everywhere. Yes, water, the basic element of life. They even give it to the plants, thus leading to the Great Dust Bowl. And what the stupid people didn't realize is that the precious electrolytes were salts building up in the soils over the years, killing the plants. And when Joe found out that they were feeding the crops with a sports drink, he said, if you give the plants water, they would grow. To which the stupid people replied, you mean water, like out the toilet? Dust Bowl crisis resolved. Now Joe, being the smartest man in the world, eventually became president. And whether or not he solved the statin and stupidity crisis, you'll have to watch the sequel. But I think it's a clever movie that really points out some of the real issues we face today. So let's get back to reality and wake up and smell the bulletproof coffee. And to realize that cholesterol is essential to life. It provides a reparative role. It is a precursor to many bodily functions. It's important and critical to brain function, and we basically cannot live without it. And when it comes to cardiovascular disease, we like to think of cholesterol as the innocent bystander, that there's other factors, namely inflammation and oxidative stress, that play a more significant role. So let's talk about that. And this is the idea that indeed atherosclerosis is an inflammatory disease. And when we look under the microscope at the plaque, we can see all components of inflammation and an autoimmune response. We see macrophages, we see foam cells, we see inflammatory cytokines. And you think that addressing this inflammatory disease would be something new, but it's not. Why? Because we really don't have a medication that specifically addresses it. Now, statins do have some anti-inflammatory properties, but it's not a direct effect of the medication. But in the late 1970s, a pathologist by the name of Russell Ross talked about cardiovascular disease as a response to injury. And the injury was to the blood vessel wall. And the cause was multifactorial, which means there's multiple factors or we don't know all the factors. But certainly nutrition, diet, insulin resistance, obesity, hypertension, smoking, all contribute, and cholesterol's there, but it's not necessarily the primary factor. And the response to the injury is inflammation to the blood vessel wall that unfortunately changes the quality of the cholesterol. You have to understand that cholesterol was there in the first place to repair the damage. And we like to think of the cholesterol molecules as the firemen coming to the fire to put out the fire, but they get consumed by that fire. So this graphic shows a progression of atherosclerosis. And Cleveland Heart Lab has created a panel of tests that attempt to predict the progression of this disease. And we'll take a look at this. So, when we address cardiovascular disease in our office, what do? Of course, we're going to evaluate the patients. We're going to look at the laboratory testing in a moment. But it starts with nutrition and redefining a diet that is anti-inflammatory, specifically a whole foods diet, a diet that is void of processing, sugar, grain, industrial vegetable oils, and yes, higher in saturated fat and higher in food quality and nutrient density, of course. And so this is my friend and colleague's picture of fish stew. Connor, who is here with us today from Modern Mediterranean, and she's been kind enough to actually bring her delicious fish stew here today, and I hope that you all have a chance to taste it. So laboratory testing. We break it down into categories just so we can understand and talk about it better, but I just want to briefly touch on some of these. The genetic testing component. And that makes me think of how expensive some of these tests can be and whether or not your insurance will pay for them. The other idea is that genetically we're all different. We absorb cholesterol differently. We produce it in the liver differently, and we clear it from the blood differently. And then the other component is the epigenetics, or the expression of the genetic polymorphism. And you have to understand all the fancy genetic testing that's available today is based on standard American diets. And we don't know the expression or the epigenetics, what it means when people are on whole foods diets. So you have to keep that in mind. So we're going to talk about advanced and standard lipid testing, cardiovascular imaging. We do carotid IMTs, and I'll mention that briefly at the end. And there's also functional testing. So, when we're talking about measuring cholesterol, we're actually measuring lipoprotein in the blood, which is a complex molecule that consists of cholesterol, lipids, fat, protein, and fat-soluble vitamins and nutrients. And it exists for one purpose, mainly to transport fat-soluble substances throughout a blood system that's water-based. Now, traditionally, we measure standard lipid profiles, and we've been doing this since the 1970s, and we're measuring these big blue subfractions, the VLDL, the LDL, and the HDL. And traditionally, we think of the VLDL, especially the LDL, as the bad cholesterol, and the HDL as the good cholesterol. I hate those terms. I just spent the first part of the lecture telling you how cholesterol is a good thing. So what we'd rather say is that VLDL and LDL is more associated with atherosclerosis, whereas HDL is less associated with atherosclerosis. And then we have the advanced lipid testing, where we can further break down the subfractions into not just concentrations, but concentrations of particles. And you can see within each subclass, we have larger and smaller particles. And as it turns out, the larger particles, we call them favorable because they tend to be associated with less cardiovascular risk. We can measure the protein molecules, ApoB 100, ApoA1, we'll talk a little bit about them as surrogates to standard testing. Also measure this LPA, which is referred to as LDL with an attitude. So standard lipid testing, which has been around since the 1970s, I think there's three schools of thought. The first school is that of nutrition-minded individuals, that we pretty much know the response to certain diets, and therefore we shouldn't even bother measuring cholesterol, and it's not predicting risk. The second school, which I probably belong to, is that standard lipid testing is wonderful. It's an inexpensive $30 test. I can run it right in my office. We get the results in 5 minutes. And the third group, of course, is those that feel that advanced lipid testing better predicts risk, and we'll take a look at that. So these numbers that I have included here are normal values, roughly, based on mainstream guidelines. Now, I don't necessarily agree with them. I've also included international units. And the bad numbers, of course, the cholesterol, total cholesterol and triglyceride, and the LDL are those unfavorable numbers, where the HDL is the favorable number that you want to be high. Now, people have criticized standard lipid testing because the LDL is calculated through the Friedewald equation. But if your HDL is not too, if your HDL is roughly within range, it provides an accurate measurement. If your triglycerides aren't too high or too low, the Friedewald calculation is fine. You can also measure direct LDL. The problem is that it needs ultra-centrifugation to measure a direct LDL, and that takes a lot of work. So we can do additional tests, and basically these are ratios where you can look at total cholesterol to HDL, which isn't very popular these days. You can look at triglyceride to HDL ratio. I think this ratio is critical. This ratio is a measurement of lifestyle, of food quality, of insulin resistance, and of the degree of inflammation and oxidative stress. Not popular among mainstream. Why? There's no medication to address it. But we love it. Okay, we have non-HDL cholesterol, which is very favorable among mainstream. And if you believe that LDL cholesterol is an issue, it's not a bad surrogate, because basically what it does is it subtracts the total from HDL cholesterol, and you get non-HDL, and you don't have to calculate LDL. I cannot measure cholesterol in my office without measuring a degree of insulin resistance. So we measure fasting blood sugar. 100's kind of high for a baseline. And hemoglobin A1C, here we have less than 5.7, which tells us how blood sugars are over a 2 to 3 month period of time. So let's briefly look at dietary effect. And what we know about is comparing a traditional low-carb, high-fat diet to a low-fat, low-calorie diet. And the effects are quite predictable. So on that low-carb, high-fat diet, we see triglycerides plummet. We see HDL go way up. Again, that nutritional ratio of triglyceride to HDL improves invariably on whole foods diets that are higher in saturated fat. More importantly, the quality of cholesterol improves. We see the large particles. And guess what's in the large particle? What kind of fat? Saturated fat. It turns out the polyunsaturated vegetable oils are the ones that are unstable, and they tend to oxidize and become inflamed. Now, the LDL response is variable. So in some we see LDL cholesterol go down, and even the mainstream doctors are happy with that result. Sometimes LDL doesn't change. The problem in some is that the LDL cholesterol, that unfavorable number, sometimes goes up, and it sometimes goes way up. And so the question is, on these types of non-standard diets, does a rising LDL predict risk or suggest that somebody's going to have a cardiovascular event? And it's my opinion that it doesn't. But I say it's my opinion because we don't have long-term outcome studies. We don't have evidence comparing diets one to the other to look at the response to a rising LDL with these types of diets. So hopefully we will have more research in the future. When we go on low-fat, low-calorie diets, the mainstream docs love it because what does it do? It lowers cholesterol, especially the LDL. It lowers triglyceride. One problem is it lowers the good HDL. But when it comes to the quality of the cholesterol, it really doesn't do a whole lot. And to try to be fair, I've seen other doctors report this as it actually decreases the quality of cholesterol because those standard diets tend to include polyunsaturated fats, which I just told you are inflammatory. And when I compare these diets, somebody on a low-carb, high-fat diet, I call them well-nourished. And on this low-fat, low-calorie diet, I call them undernourished. So we have advanced lipid testing. And understand that just like the pharmaceutical industry is trying to sell us pharmaceuticals, these labs are trying to sell us technology. So you just have to keep that in mind. And with a raise of hand, I wonder how many people have done advanced lipid testing. So not that many. So might be something to consider. We pick and choose the patients that we send out for this test. But I'm going to focus on the NMR today because that seems to be quite popular, and this one specifically measures this LDL-P, or the particle concentration. And this slide shows the laboratory printout from NMR Liposcience. It's a bit overwhelming. I really like the red, yellow, and green picture because I'm very visual. And so what I've done here is try to simplify it and to just look at 4 metrics. And the first is the total LDL-P cholesterol. So again, we're not measuring total LDL concentration, but we're measuring the particle concentration. And again, understand that the green zone that I use here is based on mainstream guidelines, and that's equivalent to lowering your LDL cholesterol down to, say, 100 or under 70. And so, again, we're treating an inflammatory disease. We're not necessarily treating cholesterol. I can't really find a good reason to lower cholesterol that low. And again, there may be side effects associated with it. So, of the total LDL-P, or LDL particle concentration, we want the majority of it to be large and the minority of it to be small. So this is the LDL-P, or the small particles. And the last 2 metrics basically look at cholesterol quality, or the size. And so you can see that if the average LDL size is greater than 20.6 nanometers, it's favorable. The last metric is one that I really created myself, basically off of their metrics, but they don't report this. And this is basically a percentage of small to total LDL particle concentration. And certainly, we want small particles to be less than half, so that the majority of the particles are large. So we can do additional testing. And we talked about ApoB, or non-HDL cholesterol, and the point is, these are just surrogates to LDL cholesterol. And the argument is, why spend more money on these expensive advanced tests when you basically get the same information from standard testing? LPA is the LDL with an attitude. As an independent marker of risk, we're not sure what it means. The last 3 numbers are the inflammatory markers from the Cleveland Heart Lab. You might be familiar with the highly sensitive C-reactive protein. It's not absolutely specific to atherosclerosis, but it does give us some idea. Some of these newer tests, the LPPLA2, they have fancy names. This is called the plaque test. Sounds good. The question is if it correlates with risk. And then the last is the cardiac myeloperoxidase. And we're experimenting with these tests because they're new and they're rather interesting. So we're going to look at 4 patients. We're doing great with time. Having fun? Okay. I am too. So this is low-carb Patsy. So Patsy was diabetic before she met me, and she was contemplating bariatric surgery. So she was looking for some other answers, and on her own she discovered the South Beach diet. She lost about 20 pounds and she did well, but she hit a plateau, and then she came to me for advice. And somewhat reluctantly, she agreed to go on a very low-carb, very high-fat ketogenic diet. And Patsy did great. It took her a year and a half, and I tell you, these ketogenic diets are just wonderful for diabetic patients. And Patsy lost 75 pounds. And we had fun at the last talk. Patsy was present. So Patsy has to lose another 40 pounds. Now, she was on several medications. We got her off a lot of them. She still has issues with high blood pressure and thyroiditis. So we're working with that. But as you can imagine, her diabetes improved, her fatty liver improved, and she felt great. And as you can imagine, her metabolic markers improved. So her standard lipid testing, and what I ask you to do is just look at the colors and don't get caught up by the numbers. If you want to talk about the numbers, we can do that at the end. So her numbers aren't really so bad. The biggest problem was the fasting glucose was high at 131. And so Patsy lost, this is before she really lost any significant weight. And after she lost 75 pounds, all the numbers go into the green zone. And as expected, her triglycerides went down, her HDL went up, and more importantly, her A1C dropped into the green range, and her fasting blood sugar went down. So that's all favorable. Her advanced testing. A lot of my patients live in that yellow zone. I don't think it's a particular problem, but again, these are the mainstream guidelines that we are working with. Although she has a bit of cholesterol, again, you can see that based on these two metrics on cholesterol size and quality, the particle size is favorably large. Her ApoB is a little yellow. She has that LPA that's high. We're not sure what to make of that, again, as an independent marker of risk. Perhaps it might have meaning if a patient's on a standard American diet, but we're not sure what it particularly means on these whole foods diets. And her inflammatory markers aren't bad. Her CRP remains elevated, and I don't think it's from any type of load of plaque, but rather her thyroiditis, so that's something we're following. Her cardiac myeloperoxidase is under 480 in the favorable range. So we do some cardiovascular imaging. This test is called a carotid IMT, and there's two components to it. The first is we try to age the blood vessel. And you can see as we age, the blood vessel tends to thicken, and we have the pink for women and the blue for men. And so her chronologic age is fine. But I've actually tried to do my homework, and as you'll see, this doesn't really seem to correlate with risk, because we have patients who have very old blood vessels with no plaque. We have very young patients, or patients with very young blood vessels who have a lot of plaque. So the bottom line, the second part of the test I think is more important, and that is whether you have plaque or not. And that's up here. These are not big balloons of plaque, but this is a 20% occupying lesion within the lumen of the blood vessel. It's a little more than threshold, but it's really not terrible. So Patsy's doing great. I think she should continue with her nutritional approach. And in terms of cholesterol, keep going. There's no need to prescribe anything for her. Next patient, Primal Eric W. We have two Erics that we're going to take a look at today. So Eric went on a primal diet about 6 months before we had met, and he felt great. He lost about 10 pounds, and he'd been going to his father's doctor for years. Now, unfortunately, Eric's father had died in his 60s from an aortic aneurysm, and of course, Eric wanted to make sure that he was healthy, so he had been following this doctor for quite some time. And as you'll see, Eric's cholesterol was never really that high based on what he was doing before, and he was always a healthy, athletic individual. And when he went on the primal diet, it actually improved. But the problem is, and his previous doctor is a very good doctor, although mainstream focused, did understand some of the advanced testing, and he did some advanced genetic testing, and a particular one called 9p21. And Eric's came back homozygous positive at 2 gene locations. And it was based on that his previous doctor wanted to put him on cholesterol-lowering medication. So as you can imagine, Eric wasn't happy with that, and he came running to me for advice. And so let's take a look at his numbers. So before he went on his primal diet, his numbers were actually good. And LDL the zone of normal or not is based on risk factors such as age, sex, smoking, so forth. So 139 is not bad. Mainstream docs typically in men don't start treating LDL cholesterol until it hits 160 or so. And you can see that his other numbers are fairly favorable. And then Eric goes on the Primal diet, and his numbers only improve. So his triglycerides again go down, his HDL goes up, which is again a favorable sign of nutrition. And this isn't a typo, his LDL in these two tests didn't change. And all his other numbers are good, his glucose numbers are good. So we looked at Eric W's advanced testing. And again, we have some of the yellow zones for the LDL particle concentration. But the two metrics here show that the particles are favorably large. His inflammatory markers are all super favorable. So when we look at his carotid IMT, the chronologic age is consistent with, the blood vessel age is consistent with chronologic age, and he has hardly any plaque, it's just above threshold. So there's nothing going on, and again, we have to consider the epigenetics for Eric on a primal diet and what it means. And at this point, I don't think there's any reason to put him on a statin. Do you guys agree? Yes. Do you agree that anybody should be on a statin? Okay, I heard some mixed comments, but just wait, it gets harder. Okay, so here we have Eric P. This picture should be on the cover of Men's Health magazine. I love it. So Eric never really had a terribly high cholesterol, and he's a very good patient. His previous doctor, again, I know him, mainstream, cared very much about his patients, but for some reason was convinced that Eric's LDL cholesterol had to be under 100. And Eric listened to his doctor, and Eric had gone through 3 medications. First, Zetia or ezetimibe, and then he was switched to, I believe, lovastatin, and he developed a true liver hepatitis, a liver toxicity, so that had to be stopped. And then he went on niacin, and at this time, Eric got absolutely fed up with this whole idea of lowering cholesterol, so he wanted to do something about it, and he went on a primal diet. And Eric felt great on the primal diet. It gave him lots of energy, but the problem is his LDL shot up sky high, and his previous doctor had a coronary. Again, there's basically not much to offer Eric. He can't take statins, and the question is, does he need to in the first place? So let's take a look. So before Eric ever started cholesterol-lowering medication, his LDL, again, was in the yellow zone. Not really a big deal, but his doctor thought for some reason that getting it down under 100 would be favorable. That's what perhaps mainstream guidelines recommend. However, Eric didn't really have any risk factors to get it under 100. But the numbers weren't terrible, and then he went on his primal diet. Now, brace yourselves. His numbers skyrocketed. Now, on the positive side, well, his triglycerides did go down slightly, his HDL went up, but his LDL went up to 191, and you can see why his previous mainstream doctor was upset. And you can see, though, that his insulin resistance is favorable. Wasn't really so bad. And now we can take a look at his advanced testing. And as you would expect, the LDL particle concentration skyrocketed into the red zone, as well as the small particles went up. But still, on his primal whole foods diet, the majority of the particles were large. When we look at his inflammatory markers, they're all fairly in the favorable zone. In fact, you'll see this cardiac myeloperoxidase was quite low, and I'm tending to like that particular test. But what to do about the high LDL-P concentration? And so this is the conundrum. This is the dilemma. Welcome to my world. We have to figure out what to do with these patients and hopefully give them reasonable advice. And the idea here is that we believe that we're treating an inflammatory disease. We're not treating a disease of cholesterol. And that's where it stands. And there's tricks you can do. If you're nervous, I have patients that even have higher cholesterol than Eric, believe it or not. And we possibly could consider cholesterol-lowering medication, but it's on a one-to-one basis. We have to individualize the patient treatment. And Eric has said to me, Dr. Gerber, I feel wonderful. We'll just follow this. There's some tricks you can do. You can switch from saturated fat to monounsaturated fat. You can do intermittent fasting. So there's all kinds of things that you can do. But the important thing is to follow your patients carefully. So we looked at his carotid IMT. Now, patients that make a lot of cholesterol tend to have thicker intimas. Does that mean it increases risk? I don't see it that way. His plaque load is at threshold, so there's again not much going on. So at this time, Eric and I have decided not to take any cholesterol-lowering medication, and we'll continue to follow. Now wait till you to see what happens to our last patient and his arteries. So this is Wheat Belly Tom. So Tom had a quadruple bypass about 1.5 years ago. But I tell you, Tom's doing great. And at the time of diagnosis, his cardiologist, I believe appropriately, put him on aspirin, a beta blocker, and a statin. But Tom wanted to do something on his own. So he read the Wheat Belly book. And like Dr. Davis said, he lost the wheat and he lost the weight. And Tom lost 30 pounds. And this is his homebrew experimental airplane. He's a pilot, and he's just gone through this whole heart evaluation so he can get back in the air and fly his airplane. But after Tom lost his 30 pounds, did I say 30? Thanks, I thought I said other. So he didn't like the idea of taking statins. So he stopped them just to see what happened. And his LDL went up. Now here's the thing, you'll see Tom never had high cholesterol. This is what makes this story interesting. But when his LDL went up on his Wheat Belly diet, he freaked out. And I had the opportunity to meet him for the first time when Dr. Davis gave a talk here in Denver. And so Tom came for my advice. So let's take a look at Tom's lipid profile. This was before he ever started cholesterol-lowering medication. Tom never had high cholesterol. Okay? In his case, it doesn't correlate with the risk of atherosclerosis. What does correlate is his insulin resistance. His A1C is sky high. And Tom, maybe he knew what he was doing or not. Now, he admits he didn't really go to doctors until he had his quadruple bypass, but he put himself on a whole foods diet, and he effectively treated the A1C, as you'll see in a minute. He improved his insulin resistance. And so we're going to take a look at his numbers after his Wheat Belly diet. And this is at the time when he had stopped the statin medication for a period of time. And I explained to him that this was actually favorable because we often see LDL cholesterol go up. And on his diet, I don't think that that necessarily means that his risk is increased. And you can see how his triglycerides went down and his HDL went up. But again, after he saw this, he went back on his statin when he came to see me, and he said, well, what should I do? And we'll answer that question in a minute. And more importantly, his A1C got down. It's still in the borderline range, and I think insulin resistance is something that we're going to have to work on with Tom, and maybe to decrease carbohydrates, maybe proteins, a little more fat in the diet, which we believe is a great way to again treat insulin resistance and the inflammatory component of that disease. So Tom's advanced lipid testing. Now, I only have the results while he was on his statin. And as you can see, the statins do a great job of lowering cholesterol. So his LDL-P his small LDL-P are favorable. It's all large particles. I don't attribute that to the statins. Again, well, maybe I didn't say this, but statins don't improve the quality of the cholesterol either. All they do is just reduce the numbers, not the ratio. And his inflammatory markers, now this is interesting. His cardiac myeloperoxidase is off the charts. And I think that tells us a little bit about the plaque burden that's going on with Tom. And his carotid IMT is unfavorable. It's hard to see, but he actually has 40 to 50% occupying lesions in his carotid arteries. Now we can talk about the quality of the plaque that we see. And what's favorable is his plaque is calcified or stable versus heterogeneous versus soft plaque, which is unstable. So that's good. But here's the story with Tom. So Tom has already had this quadruple bypass. Genetically, he makes a lot of plaque. And I think appropriately that Tom should stay on his aspirin, his beta blocker, and his statin. And like most of my patients who hate taking medication, he's still fighting with me. But I think what's important is for him to be well informed and to understand how we look at cholesterol in a non-traditional perspective. So I have some of my patients here today, and Barry is one of them, and his diet is a variant of Weston A. Price. And I'd love to present him, but I didn't have time. But he certainly has done great on his diet. His numbers look great. So let's look at affordable care. So whatever your party preference is, I think we all agree that the cost of health care is on the rise. And this chart really depicts the national health expenditure over the next 10 years. And it's almost $3 trillion, and it's going to go up to $5 trillion with or without Obamacare. That's what the two components show. Affordable Care Act, that's Obamacare. And so if we look at the trends before this time, say 10 years prior, it's the same. The cost of health care is rising. Now, say 10 years ago, we had the Bush administration and their solution to health care reform, which was the Medicare Senior Advantage Plan, which was heavily subsidized to make it look cost effective. And then the then the Obama administration comes along. They pull those subsidies out of the Bush plan to fund the Obama plan. And it's just futile. Another way to look at this is shoveling money back and forth in a futile effort. If the health insurance bubble is bursting, it's about to burst. It's a broken system, both on the financial side and on the medical side, because it's a system based on sick care. We're putting Band-Aids on top of Band-Aids, and we're not addressing prevention. They're trying, but not in the true sense. And so we want programs that'll fund prevention and wellness. But here we are in 2014. Call it sick care, call it healthcare reform, call it broken healthcare. The question is, can we fix it? And so I'm optimistic. I look at it as a grassroots effort where we want to make change from the bottom up. And we want to fund programs that will address nutrition, prevention, and addressing obesity. For instance, I'm a member of an obesity society that has an initiative to have obesity recognized as a chronic disease. And you ask why? It's not so we can make more money as a doctor, but obesity has traditionally been thought of as a behavioral disorder, and insurance won't pay for it. So if we incent young doctors, insurance companies, to learn a little bit about nutrition, perhaps they'll teach it, and these young kids in medical school will learn a little bit about it instead of just learning about what medicine to prescribe and not to prescribe. So here I am with my physician assistant, Aaron Kay, and we're trying to create a model for what we believe should be the delivery of primary care. And so we're integrating our traditional model of medical care with a more functional approach, where we're using food as a tool to treat and prevent chronic disease, including atherosclerosis. Thank you.